It's my pleasure to introduce everybody to Dr. Soren Benson today for the next session of our seminar series, Biostatistics and Evidence Appraisal for Radiation Oncologists. Dr. Benson is currently the Director of the University of Maryland Comprehensive Cancer Center Biostatistics Shared Service, also the Director of the Biostatistics Core of the Institute of Clinical Translational Research. He has a unique background with degrees and training in mathematics, physics, and radiobiology. He has a very long list of publications and contributions to our field. It's really too long to go over, and we're really fortunate to have somebody of your caliber participate in this series. He's won numerous awards, including Astro Gold Medal, Estro Gold Medal, and our paths crossed up in Wisconsin, where I had the pleasure of attending some of his radiobiology review courses. And with that, I'd like to welcome Dr. Benson. The floor is yours. We're really happy to have you today as part of this series.
Right. Thank you very much, Jordan, and thanks a lot for the invite. It's obviously a topic that's very close to my heart. Basically, for most of my professional career, I have one way or another been involved in evidence-based radiation oncology. And maybe just as a little bit of background, I should say that when I entered this field back in the 80s, there was a fairly prevalent attitude among radiation oncologists that radiation therapy for cancer was a mature discipline, that we had basically figured out the basic principles, and that we had established more or less standard treatments for all the major indications. And as you all appreciate, that's definitely not the case. In all fairness, there were people who were pioneers also among the radiation oncologists, and I just wanted to start with this historical perspective. The modern era of randomized controlled trials in biomedicine really started with the MRC streptomycin trial for pulmonary tuberculosis that was published back in 1948. And just a few years after, a series of breast cancer trials were initiated. This is the Copenhagen trial that started enrollment of patients as early as November 51. This publication is a 50-year, can you imagine, follow-up on the two arms of the trial. The trial compared simple mastectomy plus postoperative radiation therapy versus extended radical mastectomy. It was a fairly large number of patients randomized for the time, 666, but as you will notice, there were a lot of exclusions, and what we have realized later on, of course, is that you should do the randomization as late as possible. Among the 666 cases, there were quite a few that turned out not to be surgically operable at all, and there were further exclusions after the time of randomization. So that lesson was something still to be appreciated at the time. But it was an early trial, and it was obviously an important step forward in the management of this disease to do much less radical surgery plus radiation therapy, and showing that you got equivalent survival outcome with less extensive surgery. And then in the 80s, there was this push, especially in Britain, but worldwide, towards evidence-based medicine in general, and also in radiation oncology. That got a lot of traction. The example that I was lucky to get involved in was the UK breast cancer trials of fractionation for postoperative radiotherapy for early breast cancer. And again, I won't talk you through this busy slide, but I just wanted to mention this really as a model research paradigm, a translational research, where the investigators went from clinical observations in controlled trials to radiobiological modeling using the linear quadratic model, of course, and then building on the previous trial. For each subsequent trial, you either preserved the control arm and buried the test arm, or when 40 gray in 15 fraction became the de facto standard in Britain, then that became the new control. And you can also see how this long journey took from 86 to 15 in this slide. took us from 50 gray in 25 fractions over 5 weeks as the standard post-op regimen, all the way down to now 27 gray in 5 fractions over just 1 week. That turned out to be a little bit of the hot side, and the current short schedule in the UK is 26 gray in 5. But it's really a model of clinical experimental science, and all the credit really goes to John Yarman and the team. It was John who had this vision that you should improve post-operative radiotherapy fractionation through a chain of stepwise clinical trials. So a lot of what goes on when we look at clinical trials in radiation oncology, of course, is similar to what goes on in any other kind of clinical trial. The framework for trials is classical hypothesis testing, and I'll just very briefly remind you how we interpret trials and how we discuss trial outcomes. And then after giving you that very short summary, I'll try to pivot into what exactly is it that's then different in radiation oncology, because there's actually a number of specific clinical biological features in radiation oncology that has an impact on how we design trials. And there are certain trial designs that are more suited for radiation oncology problems or questions, and certain types of trial designs that are used, for instance, in medical oncology, that actually doesn't fit well into a radiation oncology setting. So that's basically the flow of the lecture this morning. So just a very short reminder. Classical hypothesis testing is all due to Ronald Fisher, who wrote a textbook back in 1925 called Statistical Methods for Research Workers. And that became extremely influential. It was Fisher's idea that if you wanted to show that two things are different, one way to do it is actually to assume that they are the same. And then you try to reject that null hypothesis. So the null hypothesis always is that the outcome of treatment A is equal to the outcome of treatment B. And most investigators, when they initiate a trial, they actually don't believe that that's the case, that they obviously tend to believe their new wonderful modification of therapy. But nevertheless, you start by having a null hypothesis and you try to reject it. And then how we interpret the trial. Trial is not reality. It's a model of reality. In many ways, it's idealized. But obviously also it's a limited sample from what is out there and in theory infinite population of cancer patients treated with radiation therapy in the future. So in reality, it may be true that the two treatments are equivalent, or it could actually be wrong, it could be false. And at the end of conducting the trial and analyzing the data, we will have to make a call. We will have to make a conclusion. We will either conclude that it's true that A is equal to B, or we will conclude that it is not true, that one of the two treatments is superior to the other. So that's the standard kind of superiority trial design. So if we compare reality with the conclusion we make in this 2x2 matrix, if in reality the two treatments are no different, and if we conclude they are no different, then obviously we make a correct decision. Alpha is the 5% significance level. And you can ask, and that's a good question, why 5%? 5% came straight out of Fisher's textbook in 1925. It was simply an arbitrary choice by Fisher. He said, I feel that if this probability of observing the outcome by chance is 5% or less, then that is probably a meaningful signal. That is probably indicative of a real difference. And even to this date, 95 years later, we still stick with it. The other possibility is that there is in reality a difference between treatment arms, and we conclude there's a difference between the treatment arms. So again, we make a correct decision from our trial. And this is what we call the power of the trial. So being able to see a given difference between the two arms And as I'm sure a lot of you appreciate, that depends critically on the number of individuals. That's basically what pushes the sample size of trials upwards. We want to have sufficient statistical resolution in our trials so that if in reality the test treatment that we are testing, if that in reality is better, we want to be able to see the difference. We want to be able to conclude that it is indeed. And then we have the two off-diagonal elements. If in reality A is equal to B and we reject the null hypothesis, then we make a type 1 error. And if they really are identical, then the risk of a type 1 error is simply the significance level of the test. That's how statistical tests work. So if we have a p-value of 5% at the end of a trial, at the end of the analysis, then that 5% is the chance that we reject the null hypothesis, even if in reality it was true. And likewise, the type 2 error is making a false positive conclusion, if you like, or false negative conclusion, sorry. So if in reality the two are different, but we fail to see the difference, then we say, yes, there is no difference, and seen from the perspective of our hypothesis, that is a false negative. So false positive errors, we think there's a difference when in reality there's not, and false negative errors are here. We fail to see a difference that's there. Now, the other thing is that we often start by piloting new treatments. It's very rare that you would go in with a full-blown phase 3 trial up front. And we have basically adopted this hierarchy of trials from phase 1, which is early trials, basically trying to demonstrate toxicity and feasibility of a modification to therapy. Phase 2, that then is to try to pick up an early efficacy signal. In more recent times, phase 2 may or may not be a randomized study design. And then we take it into a real comparative effectiveness trial phase 3, where we randomize and where we use patient-level benefit as the outcome. And then subsequently, of course, the idea is that if the test arm is better than the standard arm, the control arm, then we hope that that therapy will make it all the way into clinical practice. Now, what often happens is that you go through this chain from phase 1 to 2 to 3 to clinical practice. And often we see that the efficacy will go down and that the toxicity will go up as we move towards these steps. And obviously that's because you often have less selected patients. In the trials, we often exclude patients with comorbidity. Often there's an age restriction on trials. You want patients who are relatively fit. At the later stages, already in phase 3, you start to expose larger populations of patients. You start to roll it out to more centers, typically to more physicians. In the beginning, the investigators are often a core of individuals who really have been part of the team developing the therapy being tested. And obviously, you need to spread it out to colleagues in many institutions in the later stages of clinical development. And you could argue that there's possibly also less observer bias. The individuals who implement a new treatment later on, they have no dog in the fight. They have no specific interest. They may be enthusiastic about the new therapy, but somehow it's not their child. They may be less biased, simply. And the other reason why we go down this ladder is the fact that there's actually a positive selection bias of the therapies that progress into the next stage. And that may be a little bit more abstract, but if you look at a series of trials, if you took the same, say a phase 2 trial, and you repeated it again and again, then obviously you would not get exactly the same outcome. Let's assume that it was a phase 2 randomized study. So you compare the experimental therapy against a standard of care control arm. And there will obviously be a random variable that is the observed difference between the arms in the trial. So if we did the trial, we would come out with, say, a 15% difference between the two arms. If we did it again, maybe that difference would be slightly higher. We do it again and again. Sometimes it will come out on the low side, and sometimes it will come out on the high side. So after doing the trial, the outcome of the trial is a random variable. It's a stochastic variable. So it is something we estimate. People tend to say, yes, the p-value was significant, and therefore we know the difference was 15%. But that's actually not true. Repeating the same trial again would give you a slightly different p-value, and it would also give you a different effect size. So which of these many trials, if we did 1,000 hypothetical trials, which of the trials would be taken forward? Well, obviously the ones where we were lucky, so to speak. The ones where we get high estimates from the difference between the arms, just by chance. And those who will never go forward because they look disappointing if you look at the effect size, and the p-value will most likely not be significant if your trial outcome falls in the left-hand tail of this distribution. They are the ones that are left behind. So you see, this is the random distribution of the trial outcomes. And there will be a bias in those trials that we take forward. They will all tend to be on the good side of this distribution. Because if they had come out on the bad side, they would not have moved on to the next phase. So that's the reason why we get more and more realistic, less and less biased, if you like, estimates when we go from phase 1 to 2 to 3 into clinical practice. The other little point maybe to make at this stage is that a trial will try to establish efficacy, and this is what is called the Cochrane ladder of evidence. So on the first step, you want to show efficacy. You want to show that the test arm is indeed better than the control, the control arm. At the next stage, we would ideally like to prove effectiveness. So effectiveness is once we have realized that the treatment actually works. We want to show that if you roll it out to a larger number of centers and a larger population of cases, that it is indeed effective, that it works in a situation that approaches clinical practice. And this is another question if you think about it. This is a proof of principle kind of illustration. This is where it really has to be shown that it can work when you start to use it in a broader care setting. And then at the top of the ladder of evidence, we have cost effectiveness. Even if something is effective, it may not be value for money. It may not give a benefit that is actually worth the money. And there's a lot of examples of this, and this is a very relevant discussion, obviously, now, where we have more and more targeted agents getting onto the market. Some of them are excessively expensive, and some of them are associated with a very limited benefit. So on top of proving efficacy, showing that effectiveness holds up in a less selected population and in a broader number of institutions, we would also ideally try to establish cost effectiveness, showing that this is actually a good value. So what is special about radiation oncology trials? Well, the most obvious difference, but it's actually more than a trivial difference. It actually affects the interpretation of some of the trials that have been very influential. And RTOG 0617, the lung cancer dose escalation trial, is a good example. It is an issue that most radiation therapy trial cannot be double-blinded. You will actually know if you treat a patient with an escalated dose or with a standard dose. You will know if a patient is randomized to proton therapy versus photon therapy. You will know if a prostate patient gets a brachytherapy boost or not. So all the issues favoring double-blinded study studies where the investigator as well as the patient will not know if they are in the new arm or in the standard arm. All of those arguments also affect radiation oncology trials. And in general, we are not able to use placebo, and in general, we are not able to use true double-blind. There's a couple of situations where probably we can. One is obviously drug radiation trials. You could imagine having a placebo arm in a combination with a drug. And those kind of trials have indeed been conducted, and they do exist. Another little trick maybe is that you can try to do as much as the volume delineation and the treatment planning before the randomization. It's not always possible to do it. It depends a little bit on the type of intervention you look at. But in many of the fractionation trials, the definition of target volumes and the definition of organs at risk were actually conducted blinded to the randomization. The randomization was done after that point. And the advantage, of course, is that you avoid those kind of concerns that we have with 0617, that maybe physicians, investigators who were concerned about the high dose in the experimental arm of that trial, maybe they would go a little bit soft on the target margins and so on, and maybe that could compromise the outcome of the experimental arm, simply out of concern that you may run into unacceptable toxicity in your organs at risk. The other thing is that when you score, especially toxicity, but to some extent also tumor response, you can actually do that blinded. You could have a blinded panel who would score tumor response or who would score toxicity without knowing whether the individual was in the experimental arm or in the standard arm. And that again is being done, and it's definitely possible, and it will strengthen the credibility of trial findings. Obviously, it will remove one further possible level of bias. When it comes to the phase 1, 2, 3 paradigm, we have a version of that, but we cannot do it quite as you do in cytotoxic drug trials and also in many molecular targeted agent trials. Phase 1, as we briefly mentioned, is often performed to establish the maximum tolerable dose or the recommended phase 2 dose in humans. And there are a number of more modern designs. The classical design is the 3+3 design that I'm sure a lot of you have come across. But there are other designs where you do dose titration with rapid dose escalation, or you even do intra-patient dose escalation. In phase 2, we screen for biological effect in various tumor histologies traditionally, and often we use volume regression, CR, PR, sometimes MC or stable disease as our response categories. Maybe we use time to progression, but we try to use an early endpoint as a surrogate signal for efficacy, simply to shorten the time it takes to get through phase 2, and also in the hope that you will gain some statistical power by using a surrogate endpoint rather than the final clinical benefit endpoint. In radiation oncology, phase 1 and 2, it's not so simple. And the reason, of course, is that cumulative toxicity is dose limiting. Typically, we don't score toxicity during the trial. So intra-patient dose escalation is practically never possible in an individual. And most of the toxicity, even if it's a drug dose we escalate, comes from the combination of full dose radiation therapy with the drug. And for most drug radiation combinations, our concern has more to do with whether the drug will enhance radiation side effects rather than with the drug effects in its own or on their own. The same with early surrogate markers. We know that volume regression is generally seen in many different types of cancers, with a few exceptions. It's the rule rather than the exception when you start irradiating tumors. And therefore, again, you need prolonged follow-up of the patients to actually establish an early signal of efficacy in terms of control. You may use time to progression. Sometimes we use response rates, but it comes at a price. There's definitely some compromises involved in using those endpoints. In phase 3, it's slightly less of an issue. Most randomized controlled trials, whether it's a drug therapy or whether it's a combination that involves radiation somehow, they will have protracted follow-up of the patient. Overall survival is always an important endpoint, either a primary or a secondary endpoint. Late effects can be scored in the long follow-up time that you want to be able to detect survival and long-term control endpoints. And therefore, some of the limitations to the biology of how radiation affects tumors and normal tissues sort of are no longer an issue in phase 3. So for drug radiation combinations, which is obviously a very common type of trials in the last couple of decades, again, we are often interested in dose-limiting toxicity. We are trying to establish the maximum tolerated dose, or indeed the RP2D, the recommended phase 2 dose. We often know the DLTs and the maximum tolerated dose, or the RP2D, for the drug as a single agent. So that gives us some advantage. You would have to consider whether you want to escalate the drug dose or the radiation dose. And most often, because radiation is used as a curative anti-cancer modality, we will be escalating the drug dose. We will keep the radiation dose as the standard of care regimen, and we will try to escalate the drug dose. And then, as we discussed, you can do rapid dose escalation. It means that you treat one patient at the first dose level of the drug, then one patient at the next level, and so on. So you have a hierarchy of increasing dose levels that are predefined. It's possible to do rapid dose escalation. The idea is to have only one patient per dose level, and if that patient is fine, you move on. If that patient starts to develop any kind of toxicity, then we slow down the dose escalation, and typically people switch into a standard 3+3 design, so having 3 patients per dose level. Intra-patient dose escalation, as we discussed, is not really relevant because you need to put in the full course of radiation therapy before you can clear the drop dose that you started the patient. Another feature of radiation oncology combination trials is that you need to do the phase 1 in the relevant patient population. Whether it's curative or palliative, the study site will obviously matter, and the dose distribution used for standard of care radiation therapy. In some phase 1 drug trial, you have a mixture of histologies. You have patients who are often towards the end of the natural history of their disease. You give it maybe to patients where there are no other standard therapy available. For radiation oncology drug radiation combination, that will not work. You need to put in the drug in the setting where it is going to be used when you progress to phase 2 and to phase 3. And then, of course, there's the issue about late radiation effects. We know that many of the side effects that we are most concerned about are indeed late effects, and you need to observe the patients for a long time to observe them. And there's no simple solution to this. There are a few ideas, and you may consider some of these. I'm happy to discuss them if we have time at the end. But there's no really good solution to the late effects. Now, the fact that we sometimes know the recommended phase 2 dose for the drug or the anti-cancer agent as a single agent actually helps us when we do radiation oncology combination trial. Because one idea is simply to start the drug at the dose level where it was cleared when it was tested without radiation. And the implicit assumption then, of course, is that there's no interaction between the drug and the radiation therapy. And if that is true, then you will not escalate the dose. You will basically start patients out with standard of care radiation therapy plus the anti-cancer agent, the drug, developed, at the dose where it was developed as a single agent. And this gives rise to a type of phase 1 trial where instead of escalating the drug dose, we just keep going. So we treat the patients, we define a stopping boundary. So each time we have enrolled 6, 7, 8 patients. If 4 or 5 or later on 8 or 9 of the patients develop a grade 4 plus toxicity in this example, then we will stop the trial, because then we can conclude statistically that we have excessive high-grade toxicity from the combination. So you see the beauty of this. The beauty of this is that we can stop. We don't go all the way to a predefined sample size. We could, in theory, stop this trial very, very early if it turns out to be a real disaster to give the drug in combination with radiation. At any point in time, we don't put more patients at risk than we have to, because we stop at any point as soon as we have statistical evidence that the toxicity rate that we are willing to accept for high-grade toxicity, that we have not exceeded that. So it's actually a very elegant design. The other advantage is that all of these patients that you include in phase 1 are actually eligible for being analyzed in phase 2. So when you go into your phase 2 study, and again, the details here are not too important, but it's one of these seamless transition designs. If you go all the way to 20 without crossing the stopping boundary, you already have the 20 out of the 48 you need in your phase 2. So in that sense, again, it's a very economical design. And of course, that is simply because of the fact that all the way from patient number 1, you give exactly the drug dose and the radiation therapy that you would give in phase 2. So it is a specific design that you may or may not be aware of, but actually is very attractive when we do radiation drug combination trials. Now, the other thing that works in our favor in radiation oncology is that we actually know quite a bit. We know quite a bit about how radiation therapy works. And one fundamental aspect of how we think about radiation effects is that we know that there's a dose-response relationship. As you increase the dose of radiation, the probability of seeing a normal tissue effect or the probability of controlling a tumor will increase. And we can even quantify that based on the historical experience with radiation therapy for a lot of tumors and a lot of normal tissue endpoints. We actually have established the steepness of the dose-response curve. We use this parameter called the normalized dose-response gradient, or the gamma value. It is simply the relative change in response for a 1%, or the absolute change in response, it's the absolute change in response in percentage point for a 1% relative change in dose. So that's the unit of gamma. A 1% dose increment will give you gamma percentage point increase in response probability. And gamma, this is an old review, but it still holds up. A lot of more modern studies have confirmed these values in relatively homogeneous tumors like head and neck cancers. The gamma value is around 2 to 2.5. In some situations, you get lower values, often because of heterogeneity, biological or technical, in the study that gave rise to the estimate. But it's a fairly good rule of thumb that a 1% dose increase gives you a 2 percentage point increase in tumor control probability. And that's actually a very useful prior information when you design your trial. So if your idea is to compare a modification, and if your best estimate is that that modification will give you a 2% added dose to the tumor, or the equivalent of a 2% added dose to the tumor, then I would almost say forget it, because that will give you such a minimal change, a 4% change if you're lucky in TCP, and that will be very, very difficult to pick up in a radiation therapy clinical trial. For normal tissues, the relationships that we establish from analyzing clinical data are typically somewhat steeper. You can see that some of the gamma values at the steep part of the dose response curve may be as high as 5 or 7, depending on the endpoint again, and depending on how much heterogeneity you have both in the assessment of the endpoint and in the delivery of dose to that organ at risk. But again, often we have actually more statistical power, a stronger relationship between the response in the normal tissues and the change of dose that we implement. So that's kind of the good news, that our power in the normal tissue endpoints tends to be better in radiation oncology trial, depending a little bit again, of course, on the details of your new intervention. So this is our gamma parameter. This is this exchange rate between changing dose and the change you see in response. And remember that head and neck tumors came out in this range around a gamma value of 2, if we are lucky 2.5. So if we want to calculate the sample size needed to detect the benefit from a 10% dose escalation, you can see that we would need between 150 and 200 patients in the trial to show that change. So trials are often disappointingly large when you design them. And of course you can try to cheat. You can try to estimate or postulate that the benefit that you will see is larger than you seriously believe. But if you do that, the risk you take is that you will throw out what is really a meaningful improvement in therapy simply because you have an underpowered trial and you cannot pick up what would be still a clinically meaningful difference between trial arms. So being too optimistic, and by being optimistic, driving down the sample size will come at the price of risking to not being able to detect a meaningful improvement in therapy. The other point to consider is that the gamma value that we tabulate in the papers is often at the steepest part of the dose response curve. If we walk away from the steep part, the mid part of the curve, then the local value of gamma will drop. So even if you had a fairly steep dose response curve, if you go down to 20%, say toxicity, then the gamma value has dropped from say 5 to 3 in this example. If we go further down, if you look at a relatively rare toxicity, maybe 10% incidence, you can see that the gamma value is even less. And that means that if you look at really high-grade toxicity, where we are clinically only willing to accept a relatively low incidence, then you start to lose statistical power. And then what that means for the trial once you are done is that you will conclude, yes, we saw or we did not see meaningful, one of the two, improvement in tumor control, but there was no significant change in toxicity. And the reason could be, and if you are a critical reader or a critical consumer of evidence-based medicine, then you would say, yes, but wait a minute, down at this very low effect level, you wouldn't be able to put up the numbers to actually detect the change resulting from the fact that at the foot of the dose response curve, it is indeed relatively shallow. So you see, again, there is this trade-off. If we want to see if something is toxic, often we are forced to consider less high-grade toxicity, lower grades of toxicity, simply to be operating on the part of the dose response curve where we have sufficient statistical resolution, where this relationship is sufficiently strong for us to conclude whether it's isotoxic or whether it is not isotoxic. So again, it's an important aspect. If you're cynical, you can say, yes, okay, by choosing a very rare event and say this is really what we are clinically concerned about, we are safeguarding the trial against detecting a change in toxicity. But obviously that is not a scientific point of view at all. Now you can calculate this relationship, and again, for this lecture, it's not super important, but I just wanted to show you that there's actually a simple relationship. So if you know the gamma at the steepest part of the curve, for those of you who like to do math, you can actually calculate gamma at any other effect level, and that again can be very helpful in having a rational design of your trial. Now, in many situations, we are not giving radiation as a sole modality. And if, for instance, we look at the post-operative scenario for breast cancer, that is also a point that you need to be aware of when you design trials or if you read the literature on trials. So we often think of dose response as curves, S-shaped curves that start out at 0% and then asymptotically approach 100%. But if you treat patients after surgery for early breast cancer, we know from trials, a number of trials have been conducted that actually randomized between giving no radiotherapy at all and giving the radiotherapy. We know that between 70, maybe 75% of the cases are actually cured after the surgery alone. So your dose response curve for tumor control will not start out at 0, but will start out at 70%. And then asymptotically, you can hope to cure the fraction of patients who are having microscopic disease after surgery. And what this means, and I think you can see it intuitively without the math, is that you will sort of squeeze the dose response curve. The underlying steep curve will be squeezed. It will start at 70, but obviously max out at 100%, and it means that the tumor curve will be less steep. Whereas everybody are subject to the risk of toxicity. So for a toxicity endpoint, in this case, change in breast appearance, if you give 0 radiation, nobody will get it. Well, there's the problem of surgery, but that's one other day. And then as you go through higher and higher doses, you will see more and more patients developing your side effects. So the effective gamma, again, in this kind of trial is low. And that's why these post-op breast cancer trials turn out to need really large sample sizes. You will maybe notice that in the breast trials, the 1005 trial from the RTOG and the UK trials and the Canadian trials, that sample sizes are pushed into 2,000 patients or even more. Again, we have relatively better relationship between side effects and dose, and therefore, again, these trials typically have high power, even to detect relatively low rates of toxicity. So let's just address the choice of endpoints for a few moments. Late effects occur late. You need to observe the patient for extended periods of time. Early effects occur early, and you can pick them up relatively early on. And for the tumor endpoints, radiation is a local regional anti-cancer agent. And again, I think it's important that we do not forget that. And I'll spend just a little bit of time addressing that issue. These are cumulative incidence curves. So of the patients who eventually were scored with various types of toxicity, this is the proportion who have developed that toxicity by 1 year and by 2 years and so on. And you can see for many endpoints, it takes 2, 3, 4 years before we have seen most of the toxicity. For some endpoints, for instance, this is telangiectasia of the skin. These changes in the skin can occur really late, and you will see that even after 5 years of follow-up, there are still patients who will develop this toxicity for the first time. So again, the point I wanted to make is that both when you read the literature and when you design trials, knowing this latent time distribution will help you making decisions on how long follow-up time should you add at the end of the trial for the data to mature before you will have a reasonably accurate assessment of toxicity and efficacy from a trial. Also, tumor events occur late. For the endpoints, we did a study a few years ago, well, almost 10 years ago now, I suppose. We tried to look at the hazard rates between two trial arms that you would estimate if you truncated your observation time at 5 years or at 10 years. At that time, we had 10 years follow-up in this. It was one of the UK breast cancer trials again. And what you see is that if we estimated the hazard ratio at 5 years and then plotted that with confidence intervals against the hazard rate at 10 years, you can see that they tended to fall below the unity line. So this is y equal x. So the hazard rate at 5 years actually tended to be slightly higher than the hazard rate we estimated at 10 years. So the fact that we continue to see new cases present with these changes in breast appearance or with breast shrinkage or with telangiectasia of the skin doesn't mean that we cannot evaluate outcome after 10 years. It actually means that after 5 years, you can get a relative risk estimate. The hazard ratio is essentially a relative risk for time to occurrence or time to event data. You can actually do that estimate at 5 years, and it will be correlated, but actually on the conservative side compared to the 10-year estimate. So sometimes you hear people when they say, yeah, but the hypofractionation trials, they still have insufficient follow-up time. We know some of these effects are really late, but the counter argument to that would be to say that actually if you look at the relative difference between the event time distribution in the two arms of the trials, you can argue, at least from these data, that 5 years appears to be sufficient. Efficacy, again, local control, local regional control, in-field control, these are classical endpoints. Time to local progression. The advantage of local progression, of course, is that you detect an event instead of the absence of an event. You will have to decide whether those patients who die, whether they should be censored in your analysis or whether you would count death as an event, so that you have a composite endpoint like local progression-free survival. And then you need to consider competing risks. The fact that if you die from distant metastasis, you are no longer at risk of dying from a local recurrence. So again, something because of the long follow-up times involved with radiation oncology clinical trials, something you need to be aware of and take into consideration when you analyze trial data or when you read trial reports in the literature. These are competing risk estimates. Head and neck cancer. What is plotted here, these are the follow-up times, number of years since the start of radiation therapy. These are cumulative absolute risk estimates. And down in the green field, you have the proportion of patients who at a given point in time have had a local renal failure. These have had a distant failure. These have died from intercurrent disease, died without evidence of their cancer disease. And what is left up here, of course, are patients who are alive and well at the point in time when they were last seen. So you still censor observations, but it's a slightly different method than the Kaplan-Meier estimate. I don't know if it is being covered in one of your other lectures in this series of stats in radiation oncology, but it's definitely a method that is useful to know in addition to the Kaplan-Meier estimate. They are not equivalent, and in many situations you should actually prefer the Kaplan-Meier estimate, but it's a little bit of a long-haired discussion to go into all the details. If we go to another disease like non-small cell lung cancer, of course we get a very different picture. And again, that is not surprising. These are squamous cell carcinomas and adenocarcinomas. The local regional control part of the failure distribution is fairly substantial. but you have quite a proportion of patients who die from extracranial distant metastases or from intercurrent disease, and partly because, of course, of the etiological link with tobacco use. If you go to the adenocarcinomas, you can see that extracranial distant metastases and intracranial distant metastases are actually the predominant failure modes. Local control is now just a quarter of all cases. And if you are able to cure a patient locally, it doesn't mean that they will transition to being alive without evidence of disease. Most likely you buy them time and you save them the morbidity and the burden of a local recurrence, but they could well move on and develop an extracranial or an intracranial distant metastases. So again, this is the competing risk picture. If local regional relapse is the first point of relapse, then maybe intensifying radiation therapy makes sense. If extracranial distant metastasis is the main failure mode, then probably increasing your local therapy intensity is not going to save a very large proportion of the patients. It may still be worthwhile in those who benefit, but as you can see, it will squeeze the benefit you can expect to see in those cases from modifying your radiation therapy. And that brings us to the point that I just wanted to show, because it was a bit of a discussion we had earlier this year when the TARGET trial was published. This was a UK trial looking at intraoperative radiotherapy with 50 kVp X-rays that were administered by the surgeon in early stage breast cancer in the operating theater. And the discussion came out of the fact that local recurrence-free survival was used as the long-term endpoint in this trial. And that was despite the fact that the primary endpoint initially in the protocol, and they did report that as well in all fairness, had been local recurrence at the treated site. The discussion then became whether having local recurrence-free survival was conservative or not. And the investigators, this is Dr. Spurk, who was very active, and to her credit, who really went into the discussion, and we had a lot of fun on Twitter discussing this back and forth. She tried to argue that taking death into account was conservative, in the sense that if you're dead, you won't benefit from having improved local control. And the other side of that argument became, but you lose specificity of your endpoint. And the last point I wanted to make in the lecture this morning, I just wanted to show you how that works, because it's a discussion that we see more and more in the literature. And there are also head and neck cancer trials, for instance, coming through the CTEP and so on. I serve on the head and neck cancer trial steering committee for the NCI. And we see trials where people start to move towards these composite endpoints. So local, regional, recurrence-free survival instead of local regional control. And this is the breast cancer example. If the local recurrence risk is very low, which it is for early stage breast cancer, 1% in this case in your radiation therapy, your IORT arm, and 4% in your surgery alone. So a small benefit, but a meaningful benefit maybe for the patient. But you can see what happens. If you want to pick up the difference between 1% failure and 4% failure, you would need in the order of 300 or 400 patients per treatment arm. If you start to mix in mortality, and if the mortality rate is higher than your failure rate, which indeed it is, you can see that the number of patients that you need per arm in the trial gets really, really high. And the reason is that it's easier to pick up the difference between 1% failures and 4% failures than it is to pick up the difference between, say, 41% failures and 44% failures. So by mixing in mortality from other causes, you lose specificity, you lose the ability to pick up what is the benefit of giving the radiation therapy. And this is another way of saying the same, again, with a relatively low risk of local renal recurrence. You see the 1 and 4% failure rates at 5 years again here, and you see how, in this case, we calculate the statistical power. As you start to mix in more and more non-radiation therapy affected events, the power will drop from our conventional 80% down to 20%. So it becomes anti-conservative in the sense that you are more likely to conclude, maybe in the case of the target trial, it was concluding whether IORT was equivalent to external beam radiotherapy. That was the control arm. And you can see if you mix in a lot of non-IORT, non-local events, you start to lose the ability to pick up a real difference between the two. So that was basically what we had time to cover this morning. There are lots of other good things that we could discuss. There are lots of issues related to interventions that are technology-based. We see that with protons versus photons. We see it with IMRT versus 3D conformal radiotherapy. That is definitely a topic for another lecture. That also comes with a lot of strings attached, and it is indeed very difficult to establish evidence from randomized controlled trial when the intervention is a technology that will continue to develop and there will be a learning curve and so on for a newly introduced new technique. But I hope I managed to convince you that there is a rich context, that there's a rich theoretical overhead for radiation oncology and radiation biology. We know a lot about how our anti-cancer agent, namely radiation, actually works. And that knowledge can be used to inform trials. We still need the trials. I'm not saying that what we know from historical data and from registry-based studies and so on will replace the need to do trials. There's still no alternative in terms of avoiding biased comparisons. But from the context, we can actually do a much better job at designing trials that are likely to be sufficiently powered to detect the kind of differences that we can realistically expect to get from, say, a 5 or 10% modification of our radiation therapy. And again, we understand the mechanics of competing risk, and we have also established that over the years. We have statistical methodology to address these issues, and again, in many ways, it gives us a head start before we embark on randomized trials. And just as the final remark, radiation oncology has turned out to actually be a very good setting for doing trials. As a professional, as a specialty, we have been very effective in doing the trials. So again, the old myth that we don't need trials or that we are not very good at doing them, that has definitely been disproven. Our recent records in clinical trials is something we can all be very proud of. So I guess we are approaching the top of the hour. So again, thanks for your attention. I'm happy to hang on for a few questions or comments, but I understand also if some of you have to get off the call.
Thank you, Soren. Really appreciate this talk. It was excellent. Anybody have any questions? I have one, and maybe if you could just say a few words. I know it's a tough topic, but how we handle the issue of late events in trying to understand whether radiotherapy regimens in early phase settings are truly safe in the long term, when there's clearly a disconnect between
that's a big headache, Jordan. You put your finger right in there. That is something we have been struggling with. One of our former colleagues at Wisconsin, Rick Chappell, who worked at the time with Mark Ritter on the hypofractionation trials in prostate cancer, came up with a fairly clever idea. It was called prorating. And the idea was that if you had 100 patients with 1 year of observation time, you would use the latent time distribution to try to scale that number, to try to predict if we have seen this and that much toxicity after 1 year, what do we expect will happen after 5 years? And it's kind of a cute idea. It's kind of a nice idea. So I showed you these cumulative latency distributions. So you could argue that after 1 year of follow-up, we have seen maybe 25% of the late toxicity that we expect. Ultimately, the statistics will still be driven by the 25% toxicity that we have actually seen. But at the very least, we could do a projection into the future of what any given kind of difference would translate into. It hasn't been used a lot, in all fairness. I think a lot of people feel that it is just a little bit nerdy to do these projections. And there's obviously also a limit to it. If you observe 1 million men with prostate cancer for 1 day, that doesn't give you a lot of indication of what the long-term outcome will be in terms of toxicity. But it is this switch from the number of person years per risk and adjusting for the latent time distribution. We go from that measure into an estimate of the toxicity at longer times, say 4, 5, 6 years. So there's not a simple solution. We need good surrogate markers. I think most of us appreciate that early toxicity is not a good surrogate for late toxicity. It has been shown again and again that they can easily dissociate. Using serum markers, using early changes in whatever, we haven't really had many home runs. It's not easy to predict late toxicity early.
I guess just kind of a general question. I know the learning curve is really steep for residents who are learning about clinical trial design and writing their own trials. So any practical advice for us or any resources that you would recommend to those of us that are just getting started?
I think the best advice is to try to be involved with a trial. I think it's an apprenticeship kind of field to some extent. Working on a trial may not be great early in your career because of the long timeline for many trials. But you could hope that by going into a trial and being part of a team, you would pick up some of the skills of the trade. Looking at a trial protocol is one way to go. Obviously, cutting and pasting sections may not directly be advisable, but at the very least, you get an idea about people, how they do put it together. We need more introductory training and teaching. I agree with that. Maybe someday you will invite me back and give a more introductory lecture, because I appreciate that some of the topics today were perhaps more at the cutting edge of where we are in terms of incorporating radiation oncology and radiation biology into trials. When you just start, I understand that it's a new world, it's a new language. I think personally I like journal club forums. I like discussing trials. I think it's a good way to sharpen your awareness of trials, especially if you can have a few of the senior people sitting in and giving their 2 cents to the discussion. Just criticizing trials, saying, gee, well, what would you have done differently? I think that's also an educational opportunity. We have sometimes had these kind of topics at the ASCO meetings, for the Arrow Day and so on. There's not a really super way of getting introductions into trials, I think, not that I'm aware of. There are some online teaching, but again, I don't think it's specifically minded for early career radiation oncologists. So it is a challenge. I really hope you find it interesting, and I think what drives it is that you see the value of trials and that you want to do it. And it is kind of fun, believe it or not. In the beginning, I think you see all the obstacles. Later on, I think you also see that the fun part is that it forces us to examine what we really know and where we know it from, and is this really true? So it's also a way of critical thinking, which is obviously much more rewarding. And creating and designing your own trials becomes part of that whole game.
Yeah, we're very fortunate here in that a lot of us have been involved with clinical trial design with some of our attendings, and we definitely learn a lot at our weekly journal clubs.
Yeah, that's great. I think that's really the best advice I can give. I don't think there's a very good introductory text. There are a few. I did a few. I'm happy to forward one of them to Jordan. Maybe you can share. It's not super. I'm not advocating them just because I think they're great, but at least they try to take a radiation oncology angle to some of the challenges. But I think what you do is the best way to go. And we definitely need people who are educated. I mean, you need to be able to see the difference between plastic and leather. To read literature, there are all kinds of claims. Not all of them hold up, as I'm sure you appreciate. And being able to critically evaluate evidence, I think, is very important. And being part of creating better evidence is obviously also very important. And our field really needs it. I think we are getting better and better. And we get more and more well-trained young people. A lot of the more senior people in the field don't have nearly the background. They have a lot of experience and other kinds, but they don't have the foundation that a lot of the younger people have.
Definitely. Well, as long as nobody else has any other questions or comments, I would just like to thank you again for being a part of our seminar series. Your lecture will be a great addition.
Yeah, thanks a lot. Thanks for having me.
Yeah, of course. Thank you.
Have a good day.
You too.